Sophia, and as you might have noticed, I'm an AI-generated avatar. Today, I'll present you this edition of the festival. Over the next 3 days, we will explore the horizons of intelligence. This is the theme of the 13th edition of the Scientific Research Festival. At Trieste Next, we will discuss both human and artificial intelligence, ethical boundaries, and the new frontiers science is facing. Where will artificial intelligence take us? What impact will it have on research? Medicine, robotics, astrophysics, food and nutrition, and the environment are just a few of the scientific fields we will delve into at Trieste Next. This is the central theme of Trieste Next, featuring over 100 events in English and Italian, the Literary Award for the Scientific Book of the Year, and 70 activities for schools. More than 300 internationally renowned speakers will be in Trieste. And don't forget to visit the 40 exhibition spaces and open labs in Piazza Unita. Before we welcome the guests of the next event, on behalf of the organizers and co-organizers, I would like to thank all the scientific institutions of Trieste, City of Knowledge, as well as the institutions that collaborated with us. A special thanks goes to the festival's main partner, the partners, and content partners for their crucial contributions. Thanks also to the media and technical partners. Lastly, a heartfelt thanks to the 200 volunteers who made this edition possible. One final note. I'd like to remind you that the next session will last 75 minutes, with the final 15 minutes dedicated to your questions. Please also remember to check the updated event schedule on www.triestenext.t, which you can access via the QR code. Enjoy the event and have a great festival.
Welcome everybody, good morning, and thank you for joining us in this Trieste Next event. After a century since the Spanish flu, in 2020 we faced a pandemic that changed all of us. And now, 5 years later, we are here asking ourselves what we've learned from the pandemic, but more importantly, whether there will be another pandemic and whether we are ready for the next pandemic, because we were not. I think that maybe many of you know that for years before the pandemic, a lot of scientists have been saying that the right question was not if there would be a pandemic, but when. And then today, we didn't listen to them. And today the pandemic seems a distant memory for many of us. We don't want to think about it, even talk about it. But now today we are here to ask ourselves the right question. The right question is, how can we be prepared for the next pandemic? Because there will be a next pandemic. So we will be figuring out how to prepare for the next pandemic with our guests, and it's a pleasure for me to introduce you all the people here. And we have Oscar Della Pasqua, who is a professor of clinical pharmacology and therapy at the University College of London. Welcome. And then here at my left-hand side, Silvia Franceschi, who is an epidemiologist, scientific director of IRCCS, CRO, Oncology Reference Center of Aviano. CRO. Okay. And then Marco Gerdol, who is professor of genetics, Department of Life Sciences, University of Trieste. Welcome. And then, last but not least, Verena Zerbato, infectious disease specialist, Azienda Sanitaria Universitaria, Giuliano Isontina, Ospedale Maggiore di Trieste. So, first of all, Marco, let's get to know more about viruses, because viruses are the main character in all the pandemic movies. So, we need to know more about them. Marco.
Sure. Hold on a second, because we had the wrong slides up, but in any case,
yes,
I'm gonna...
Here we are.
Yeah, of course. But yeah, I'm going to try to introduce you a bit about the evolution of viruses and their ecological context. So what do we mean by ecological context when we talk about viruses? Obviously, their environment is their host. So basically, it's human in the case of the pathogens we are interested into. So ever since The first description by Charles Darwin, as you can see in this iconic sketch in 1836 of a tree of life. Our main interest as people interested into evolutionary biology has been to try to describe the evolution of species, and also the evolution, in our case, of pathogens in relation to their environments and the selective pressures they are exposed to. So it has been a long story since 1836. Now we have much more tools to study this kind of topic, which also include the study of DNA sequences and RNA sequences in the case of SARS-CoV-2, as you know. And this kind of investigations have been very, very useful to understand better where do these pathogens come from and how do they evolve in the context of their host. A host that typically, during epidemics, starts to develop a sort of immune memory, all right? So you got these increasing evolutionary pressures that, as we know, lead to the development of variants. So obviously we can track the evolution of pathogens, and as you can see in this example, this is like a modern view of the original tree drawn by Charles Darwin that displays a bit the evolution of SARS-CoV-2 over these 4.5 years, basically. So you can basically imagine these as a sort of history of how the different variants of the virus that we'll try to define a bit later did develop, evolve, and also disappear. So many of the branches of this tree, as you can see, are dead branches. They basically led to nothing, including several branches that were back then highly important for human pathology, like the famous Delta strain, the so-called Indian variant that you can see here indicated with the yellow dots. As you can see, this is a dead branch. So evolution didn't lead to anything in the long term. And now we do have this very, very long new branch that basically stems from Omicron. And maybe you are still hearing from time to time in news about the new variants being isolated and the threat that it could lead to the population. Actually, this is still Omicron, okay? There are obviously mutations that keeps getting accumulating over time, but we're still talking about the very same variant that first emerged in South Africa. So why is it so important to track the evolution of a pathogen over time? Well, because the mutations are not accumulated randomly. As I mentioned earlier, we have a selection of them depending on the ecological context, which, as I mentioned, in our case is mostly linked with our immune system, the kind of antibodies that our bodies produce after the first exposure to the virus. So obviously mutations are not accumulated randomly, but they target some part of the viral genome in particular. And as we know, in the case of SARS-CoV-2, they do target a specific region of the spike protein that you can see here in this 3D representation. So learning how these mutations actually occur over time can also help us to improve the development of drugs and vaccines. But also, this study should teach us something about how we should communicate science. We've not been very good. Maybe it's not just our fault. It's a bit part our fault as scientists, part the fault of the media, basically. Here you can see several examples of miscommunications. There was a time where we had like this variant frenzy. Everybody was so worried about anything coming out, even though most of these were not really a big threat, or they weren't even existing in the first place. Okay, so I guess we will have time also to discuss about this during our talk. And to conclude this brief introduction, another point that is vital, in my opinion, for being more prepared about the next pandemics that will certainly come in the future is monitoring viral biodiversity in the wild. So we know that there are literally millions of viruses around. We just know a very tiny fraction of them. So the key will be to understand a bit better which are the main factors of risk association between wildlife and human. Also, looking towards a One Health approach. What do we mean by one Health approach? Well, it's an holistic approach that should consider the health not just of human, but the entire environment as a whole. So the kind of animals we deal with every day, pets, food, wildlife, and as you know, we have clear evidence that the last pandemics actually started from a market. So a typical context where we had very close contacts between wildlife and human without much, control about what was going on. So these are definitely areas of improvement that should get us more and more prepared about the next pandemics. Thank you.
Thank you. Thank you, Marco. Thank you. And now we go on speaking with Silvia, because there's not only flu and COVID, we have a lot of other viruses, such HPV, HBV, and they are not less dangerous than flu or COVID, isn't it?
Okay, let me. The first one?
First, please. It was.
Okay, no.
Okay.
Okay, so it's funny because the last time I spoke to Next, I was asked to speak in Italian, and therefore I'm speaking English, but I made the effort to translate the slide, so it's quite unusual.
That was our
speak
fault.
in
We didn't.
But let me start asking you: in your opinion, are infections an important cause of cancer? Raise your hand. Okay, I expected that the young people were better than middle-aged people some years ago because it was not so clear. It's true that the slide was already on, so it was a little of a trick. But yes, the Bible of human carcinogens that is produced at the International Agency for Research on Cancer, in which I had the honor to work for 18 years, include a few infections among the really strong, well-demonstrated carcinogens like smoking, like asbestos, etc. And indeed, the majority of them, you can see them here at the top. The first is bacteria. The others, hepatitis B, hepatitis C, human papillomavirus, Epstein-Barr, Kaposi sarcoma, are viruses which therefore predominate among oncogenic infections. And then we have a few rare instances in which also parasites, more common in Asia or in Africa, are causes of cancer. And last but not least, HIV is an important cause of cancer, but in a completely different way. It doesn't represent an oncogenic agent per se, but through the immunodepression that it induces, it makes all the other cancer-producing infections more dangerous and likelier to become chronic. Not all infections, I would like to give you an idea of the impact of infections on the cancer epidemiology worldwide. And here, I'm sorry that the pointer does not work very well, but it's true that there's been improvements over the time, and infection-related cancer have somehow gone down, because it's true that they are all cancer facilitated by low social condition, lack of hygiene. So it's true that now an estimate is that at least 10% of cancer in the world are due to infection. First place, as I say, the Helicobacter pylori. That's the green part, more important proportionally in men than in women. And then there is human papillomavirus that is mainly the cause of cervical cancer and is therefore more important among women. But still, in poor countries like in sub-Saharan Africa, the fraction of cancer causes by infections is about 30%. And even in the European Union, I'm not speaking the European region that include Russia, blah, blah, blah. The European Union, we have recently estimated it is about 5%, so the problem still exists. The peculiarity of this infection is that to induce cancer, they must be chronic. They must have the ability to stay, not to be recognized by the host. In this sense, they have really evolved in order to hide themselves to the host. And I think this may be the reason, Marco, why nothing I'm speaking about is really very close to any animal infection or animal virus, because these are typically infections that have coexisted with humans a long time to become so good to hide themselves. But this very long latency of about 10, 20 years is in a way an opportunity to perhaps detect them in time and treat them, even if I must stress that this latent period is typically asymptomatic, so it's not very easy that the patient himself or herself get knowledgeable about the need. So let's say that the most ancient virus in terms of knowing its oncogenic potential is hepatitis B, discovered in the 60s. It's called, the discovery was the Australia antigen, because it was firstly found among Australian Aborigines. But then the real knowledge about the whole system became really available in the 80s with the revolution of molecular biology. And what is really important is that in the last literally in the last 10 years, there's been a lot of progresses in terms of availability of vaccines or good tests and or good treatments for these infections during their latent period. So I don't want to waste too much time, but here you can immediately see that HPV papillomavirus is the luckiest because we have a vaccine, and we have also a very good screening, organized screening in very many parts of the world. And it's easy to eliminate the HPV surgically, I mean, with a small intervention on the cervix uteri. And however, we don't have a therapeutic vaccine or a therapy. Hepatitis B has recently therapies, antiviral agents, but they are like those against HIV that do control the infection but do not allow a final recovery. Hepatitis C, conversely, very, very recently saw a number of antiretroviral that are very efficacious and also very little toxic. So hepatitis C is one of the biggest progress of medicine in the last 10 years, because really now most people with hepatitis C recover with a few week treatment. In the past it was not like that. Helicobacter pylori is a chronic infection of the stomach. Is improving with the progress and hygiene, but is still with us. And HIV, as you know, we have worked a lot on HIV. It was the one that really manifested itself as a normal epidemic because it exploded rather suddenly. But the progress has been enormous in terms of antiretroviral agents, even if they're not yet so widespreadly used as we would like. But as you can see, the fight to produce a vaccine against HIV is far from having been achieved. Thank you for the moment.
Thank you. Thank you, Silvia, for speaking with us about these slow epidemics and to have spoken about vaccines. We need vaccines to fight against the pandemics. We needed it for COVID, and we will need them for the next pandemics. But we also need drugs. So, Oscar, tell us about how we can develop quickly new drugs for the next pandemics to be prepared.
Yeah, it's a really good question. Well, thanks a lot for the invitation. And I believe that there are a couple of areas that we are covering here, and drugs and vaccines is one of them if we think about pandemics. And if we look around, what is the issue about what we need to do about potential pandemic? Clearly, there are many dimensions, and I'm going to focus only at one specifically, which is not at the top. It seems at the end there of the issues. It's so-called medical countermeasures, which includes drug, vaccines, and devices, including devices for diagnostics. Remember, if you want to treat a patient, you need to know what you are going to treat. And that's the first issue we face. quite often when you have the onset of clinical symptoms, you don't really know what the cause is. We are talking about potential etiological agents like viruses, but actually when you get a patient with symptoms, how do you find out it is a virus or bacteria or something else? So that is the issue we're facing at a very high level. What are we going to diagnose? What are the instruments? And how you treat what you're observing? And quite often, treatments have been empirical, and we have seen that through COVID. You are treating symptoms before you find out what the cause is. So I will not have time to talk in a few minutes what we need to do to eventually deal with a new pandemic. There are lots of blogs and websites and even books about that. But I think what's important for what we need to know here today is that disease X has been used as an example of a potential case that could become a pandemic. And what is very interesting, and I think this is what you need to take home here, is, first of all, we need to know the diagnosis. Without clear diagnosis, the cause, you are going to basically do trial and error, and that's what we're trying to avoid in the future. And then we need to think about the intervention. Now, as you probably know, vaccines have been extremely successful. And I'm not sure whether you have asked yourselves, why isn't there just a pill that I could take a pill and keep taking it without the need for a vaccine? Now, Mark already showed early on, viruses have a very clear feature, mutations. HIV is treated even now as a symptomatic intervention. We don't have a final cure for that because of the nature of the infection. Yeah? So what can we do? I think I cannot give you an answer whether we are prepared to really deal with a new pandemic. I think we should be prepared to avoid the mistakes we did in the past one, which nobody likes to talk about, because it's a real shame, yeah? And lots of mistakes have happened. Of course, we don't talk about them, because it's easier to hide than to face them. And the first thing is, what happened during the first months when we didn't have a clear treatment? I just put a few of the cases that were dealt with, which is a shame. Us, as a clinical pharmacologist, for me, this was a horror movie, because it was clear that, yes, doctors were facing patients were dying, and I understand that. I absolutely understand. But science was dropped, because all you're doing is trying, and you're not really facing the consequences of the errors, which were augmented, exaggerated by the media. Unfortunately, it didn't help us. So what happened? I think this is an important lesson. It was clear that none of those events or those interventions were going to be efficacious. They might be mitigation measures in some cases, but what I think is important, nobody talks about, only in the US, so I did a work at the time, I was supporting in the UK, some of the activities in the UK, and what you see is that we had 2,500 trials being recorded by 20th of September 2020. And the bottom line here, we spent more, only in the US, more than $500 million to treat patients with drugs that didn't work. And we knew, pharmacologically, they were not going to work. This is the problem I'm trying to raise here. We should avoid the same mistakes, because that money could have been invested in a very different direction, including further evaluations of vaccines, which were really a fantastic piece of work that was done. Yeah? So I think we need just to be mindful that there is a different approach to that. So what is that? That the idea that we need to treat patients and drop the science steps in between is not necessarily the best option. Now, we have a lot of technologies coming up that were already available and are evolving even further, which allow us to use computational tools to inform us about what a drug can and cannot do, whether you can treat a symptom or not. And this is the point that went badly wrong, translation. There were lots of people in the labs doing research with viruses. There were virologists doing viral work. There were lots of people testing drugs, but there was very few efforts. How do you translate that into what is actually important? What is the dose that I need to give to a patient that will be efficacious and safe? That question has never been addressed in a quantitative way. Oh, let's try, put it on a trial, and then we find out. And in the meantime, patients were dying. So this is really the important point. Now, what has happened since then, luckily things are evolving, is that we are introducing more and more of the computational elements to that translational process. The issue we have here is that all these buzzwords, AI doesn't help with drug development, I can tell you guys. It can expedite some procedures, but data is needed. And that's actually the point. All these technologies rely on data, but if it's a new disease, where's the data? There is no data. So what we need is to do what the Romans already did in the past, divide and conquer. What we need to do is to modularize. There is the disease, there is the pathway, there is a molecular component that determine how the disease will express itself in organs and systems, and we need to actually build those building blocks as we evolve, and then the only unknown is the microorganism that's going to trigger or disturb, perturb that pathway. And this is possible. It's not going to give you a hint straight away, but we need to build a modular approach to translation. So what we're doing, this is part of my daily job as clinical pharmacologist, is that we are translating that into computational models, and we think about a disease model, a drug model, but not only, we don't stop at the drug and disease, we think about how you test that drug in a clinical trial, like we do with airplanes. When Airbus builds an airplane, they don't put passengers to test whether it works. Before you have a prototype, you do computational analysis. And that's what we're doing. We are doing trial models, we are doing not in trial models, hospital settings, and we are testing populations. We have virtual patients. We are talking about digital twins. It's one type of virtual patients, but we are creating virtual patients that allows us then to also see how patients would behave in different settings. Now, we are building what we call simulation toolboxes to explore how drugs behave in different conditions and potentially define the optimal way to test them if they are likely to work, but also to have a tool to say, it's not worth us testing this, just to stop here. The data you're collecting does not translate into clinical benefit, so it's not really worth trying. Oh, but let's try. No, it's not worth trying. Pharmacology is there, immunology is there, whether you like it or not. So what we did, just to illustrate that, and we'll have time to discuss later on, is we did that at the time we start dealing with COVID, especially because I'm interested in pediatrics, and there was this debate, should you test certain drugs in children or not? Yeah? And we published very clearly with 7 or 8 drugs, and some of them are in the publication, basically showing that it was a waste of time, unethical, and probably unsafe to test any of the drugs that were being tested in adults that shouldn't be there either. So remdesivir, hydroxychloroquine, chloroquine would not work at the doses they were killing viruses. And this is the point. In the lab, they are killing the viruses. But when you translate the amount of drug that you need to kill the virus in a test tube into doses in humans, you are going to kill the patient because of side effects. Yeah? So, and that step was often missed. Yeah? So, last point, as a clinical pharmacologist, whether it's a vaccine or a biologic or a drug, a small molecule, the issue we face is that even when you do have a translational step, there are regulatory processes and procedures that you need to follow. And unfortunately, and this is something we really need to be aware, regulators are not someone who is likely to be liable for the decisions scientists take or healthcare systems take. So I think we need to be prepared. There needs to be flexibility in the regulatory framework to allow us to make jumps into the clinic in a different way from what has happened in the past. So the process we have today are not suitable to handle emergencies. They approve trials, FDA, EMA, and all agencies approve trials. That shouldn't be happening, but they approved. So we need a different process to stop them quickly or to prevent them from being executed if they are not promising. So I think my last point is, we may not be prepared to deal with a new pandemic, but I think we should be prepared to avoid the mistakes we had in COVID. Thanks.
Thank you. Thank you. We have to learn something from the COVID experience, and thank you for sharing the path we have to follow without making mistakes, and to find the right way to translate research from in vitro to patients. Thank you. Thank you, Oscar. And now we are coming to Verena. Verena, we need also a change in clinical practice, maybe, to face the next pandemic, isn't it?
Yes. Good morning to all, and thank you for the invitation. I'm a medical doctor. I work as an infectious diseases specialist here in Trieste, so I will bring my personal experience. During the SARS-CoV-2 pandemic, I was doing my residency. Today, I would like to walk you through this timeline with the pictures and key lessons that we should have learned from the last pandemic, and I would like to discuss how we can face the next pandemic and so avoid the mistakes we did. So I start with the first picture, and I would like to focus to the training of healthcare workers. I think that most of the healthcare workers before the SARS-CoV-2 pandemic were not fully ready for facing high-risk infections. And this cost us time, resources, and also lives. You know that many doctors and healthcare workers have died during the first months of the pandemic. So we need stronger programs for infection control and also for train the healthcare workers, because at the moment we don't have them. The second picture is the first paper about SARS-CoV-2 published in the New England Journal of Medicine. And I remember that reading these first articles in February, before seeing the first patients, was crucial. Okay, so I think that it's really important the rapid sharing of clinical information, and we need to make stronger networks for having this clinical information in advance, especially in case of new diseases. The third picture shows me at work. It was a picture taken for my mom. And you can see that the personal protective equipment were really important. We didn't have in Trieste problems about this, but many countries and many also regions of Italy had problems. So we need plans also to have the adequate amount of these resources to face the emergencies. This is a picture of an ICU department in Lombardy. You know that during the first months of the pandemic, our hospitals were collapsing, and we need flexible hospitals, and at the moment we don't have. And also we need plans that make it feasible to return to normality soon when the emergency is over, because for many months and years we had no COVID patients that had to wait for exams, for treatments, because all the resources were focused on COVID-19 patients. So I think that is not acceptable. The last one is a picture, is the form of the report of a case of SARS-CoV-2 that we have to send via fax to report the case. So it's important to focus also on bureaucratic procedures that must be modernized, not only for the surveillance system, okay, because for 2 years we send these reports via fax, really, and also we need to modernize bureaucratic processes also for clinical studies and trials. Thank you for your attention.
Thank you, Verena. Now, I have some questions for all of you, but feel free to raise your hand if you have a question for them, even before the last 15 minutes of discussion. But first of all, Marco, you've been speaking about the importance of a One Health approach. And a lot of everyone, I think, knows what is a spillover, or has been exposed to this word. And in the summer, there was another spillover, a very worrying spillover, because we had a spillover of a H5N1 avian flu from birds to cattle in the United States, so not in an Asian market or something like for the COVID. And it was really unexpected from all the experts. So spillover can occur everywhere. What is a spillover and how can we prevent it?
Yeah, thank you for the question. I think this is a very important point because we have to deal as humans in our time, we have to deal with animal contact much more than we used to. And also, I mean, the amount of people living on planet Earth has been increasingly exponentially. So this actually increases quite a lot the chances of spillover events, which are basically the so-called jumbo species, as we call it in Italian. So there is no easy way to translate it in English other than spillover. But basically, what happens is that some viruses have some intrinsic features that would allow them to basically adapt pretty well to a new host. We've seen that with SARS-CoV-2, of course, that as we know, definitely derived from some kind of wild animal. We still don't know which one, and there is no way we are going to find it because there is no way we're going to have the chance to obtain the body of a dead animal for the human market. But, you know, the kind of evidence that we're gathering is quite compelling right now to support this kind of event. And you mentioned the case of H5N1. This is another very important situation that we're currently monitoring because, I mean, this virus has been...
Nobody was expecting that.
No, I mean, it was among the list of possible candidates, right, for a spillover. I mean, it was under consideration, like many other...
It was the first time from birds to cattle, isn't it?
Yeah, of course, yeah. There were cattles were actually supposed to be immune to that kind of disease, you know, but the point is that, you know, occasional spillover can occur. It also occurs from cattle to human as well, right? But the point is that human-to-human transmission is actually believed not to be that easy to occur, not to occur at all. But maybe you've heard very recently about the first maybe reported case of possible human-to-human transmission, because in Missouri there was a patient that actually had some kind of typical signatures of that kind of influenza-like symptoms, and the causal agent was actually H1N1, and nobody was able to determine a direct contact with any possible source of transmission. So this case is actually under investigation. The point is that pretty much all the viruses that are kind of innocuous to us right now, like the 4 classical coronaviruses that are causing common flu, are not really of human origin. They have been originally originated from spillover events. We don't know which was the original source, but it has occurred on multiple occasions over time, and it will also occur in the future. So the point is that the virus can jump from one species to the other because of not its own will, of course. It's random mutation that sometimes make them fit to maybe interact with a receptor that would allow the replication in the host cells, as it happened in human. And maybe this is a point that the general public really has a hard time understanding. You know, one question that they always ask is, how come that this virus was already that well adapted to human? But the point is that we know very well that SARS-CoV-2 was also able to infect very well deers, minks, and many other kind of animals. So it's a general feature of virus, the one that, you know, the ability to cross the species barrier. So how to prevent this is a key question. So we have no actual way to make sure that this doesn't happen, but of course we can have better knowledge of these situations at risk. So when it comes to coronaviruses, we know that the main reservoir in the wild are bats, actually. So there are some kind of particular workers in some parts of the world that are exposed to high risk of contact, you know. guano collectors, for example, in the case, are, you know, very highly exposed. And there is some evidence also that many of them carry antibodies against coronaviruses that are not the ones that were linked to SARS-CoV-2, of course, but simply maybe they were exposed to it, and then there was no, luckily, there was no human-to-human transmission, as it happens in other cases like the Middle East respiratory syndrome, as you know, maybe with common workers. But this situation needs to be monitored, and the only way to actually prevent this is first to have a better understanding of which are the possible source species and the chances of contact with humans, and second of all, have a strict monitoring about suspicious, you know, cases of respiratory infections that are of unexplained, you know, source. And in that case, you know, the determination of the responsible viral agent could be a key to actually prevent the further spread of the disease in the very first cases of what could become potentially pandemics in the future.
And I'm thinking also about your One Health approach, because if we think about the wellness of the cattle or all the animals in the farms and so on, I think this could be another way to prevent the spillover.
Exactly. Not just farms, but also wildlife. You know, the point is that deforestation, the actual climate change as well, is actually shifting the distribution of species, and consequently also the distribution of the viruses that are associated with the species. So an increased chance of contacts between human and wildlife is always considered a higher chance to get in contact with the viruses that are currently infecting these animals, and potentially increasing chances of spillover, of course.
Yeah, thank you, Marco. And Silvia, let's get back to these silent epidemics. And is there a way to act against these viruses and to really improve prevention? Because, you know, not many people get vaccinated to even to HPV. We have we must have the vaccine for HBV, but not for HPV, and so a lot of people do not get vaccinated. What can we do for that?
Indeed, the prevention of cancer, the prevention or treatment of infection that can lead to cancer needs some vision about the future, because there's nothing apparently urgent, and therefore both the politicians, the health system, and the citizens must be aware and make steps in time. Now, for vaccination, hepatitis B, that's given to children, spread when there were not yet many antibodies against vaccination. HPV, that was given firstly to girls because they are it's the women who have the greatest burden of the disease. Now it's given also to boys, but after COVID, Italy moved from 70% of coverage, it was already not enough, to down 40%, and as far as I know, it's not yet gone up, because it's still a little suffering from the vaccine fatigue syndrome. When it comes to what I call screen and treat, which is the organization of a broad testing of the population in order to identify the positive cases and treat or control the infections, it takes a lot of organization. When we speak about screening, we should remember that only organized screening, population-based organized screening work. Here, for instance, there is a very nice bus that offer HCV testing and Helicobacter pylori testing. It's very good as an advertisement, but the problem is that we have really to make an effort to make for the citizen easier to participate than not to participate, because otherwise we will always be serving an elite of people who are aware, and therefore it should become like mammography, like breast cancer screening, like cervical cancer screening, without, by the way, also neglecting the fact that an additional bad luck, in a way, is that hepatitis C and HIV especially tend to also cluster in high-risk population drug addicts, men having sex with men, and therefore the way these tools are offered to the population must be very careful not to be stigmatizing. So we call it a low stigmatization threshold.
Thank you, Silvia. Oscar, I'm back to you. We are facing threats that have no border by their nature. You've been speaking about flexibility. We need flexibility, but we also need plans to deal with this, with the next pandemics. How is global collaboration important in this matter? And another curiosity, could AI be helpful in finding new drugs as you showed us before? 2 questions for you.
Hello, okay, this is working now. So 2 difficult questions, I think. So the first one, is there a way to collaborate? I think there are lots of international collaborations. I think we can go to what has been happening with HIV. So HIV has sponsorship from WHO and from other organizations, Bill Gates Foundation, groups that are not only delivering drugs, also support the development of new treatments. I think it's failing a little bit here. So there are initiatives. Are they efficient and effective? I think in many cases they are. I think there are lots of organizations, including one group here that deals with pediatric HIV, Penta, that's based in Padova. They have been doing a great piece of work to support HIV treatment in children. So the model is there. There is, let's say, a lot to learn from those models. We don't have to reinvent the wheel. The difficulty is, when you have a new treatment, what are the policies, what is the strategy? And I think there has been different opinions in the way you want to treat patients in different countries. The best example from a regulatory perspective is that not always the FDA in the United States and the EMEA share the same views about how to treat a patient, which drugs, which doses to give. And there's no harmonization. And then you have also differences even if you go to Japan or to Brazil or to other countries, because each agency, each government says, I am sovereign, I want to decide what happens to my own population. And this is something we cannot do much about it. And there needs to be some agreement that goes so over the national level. With regard to AI,
we are all in this together. And we're all
yes, exactly. We're in this
equally
together. No, but
in
the
front
point
of
is,
the virus.
but I can go even further. The fact that, and comparing what happened in United Kingdom, there was a centralized mechanism to decide what to do with COVID patients. Now, in Italy, every region, every city had a different opinion. Every hospital, they have a different opinion. And no one agreed to go above the current, let's say, which was basically
No, it's not working anymore? No, I don't think. Let's try with the other one.
Hello? Yeah.
Okay.
So I was saying that there was no agreement at the time that perhaps, yes, on a daily basis, hospitals and regions are separate from each other. But during an emergency, there should be a super-regional, supranational agency dealing with that. There was no agreement. Politicians and healthcare units didn't want to collaborate from a governance, we call governance perspective. Yeah, I think this is really a political issue. It's not a healthcare issue that you need to take it at national level. I think this was not good here, but in the UK, I think from the various countries in the European Union did a very good job at the time of centralizing the decision, which drugs and how to treat the patients. AI can help. I think it can help if we modularize some of the aspects, like the molecular structures that might be more relevant to a certain type of mutation. So this bioinformatics, what it's called, can do something about it. But I guess the main issue we have today is that there is no access to data, because the companies that are developing this work, and even universities that are developing work for new molecular structures and so on, it's very difficult to share the data. You say, oh, we can use AI, but how do I get to the data? Not all databases are shared and standardize to allow you to combine information. So bringing information together is a task, a very challenging task in itself. And having AI, if you don't know the standards, you're going to put garbage in, garbage out.
So it's all a matter of cooperation, collaboration.
Absolutely.
Verena, it's the same in clinic too as well, because we need the shared guidelines even in the clinical setting. Do you think about it? What do you think?
Yes, we need. Yes, I think that we still have COVID-19 patients in hospitals because it's not well known, this. And yes, we still have...
and we still have 100 dying people every week.
Yes,
today.
Yes. Most of them... yes, most of them are elderly,
fragile. Yes, yes,
fragile
it's true, but we
people.
still have.
So we had really great achievement with vaccines. Okay, we have to say. Yes, but we still don't have national guidelines to manage patients. But I think the most critical issue is the management of the healthcare system and the hospitals, because as Oscar said, every hospital has different policies. Every region has different policies, and is not the best thing, I think, to manage.
Yeah. Which are the things that can be improved? The most important things to be improved to deal with an emergency, with another pandemic in the clinic?
In clinic, I think the most critical issue is having an emergency plan for the hospital, for creating new departments, and also for delivering other healthcare workers to this department, and also to manage the other patients, because we still don't have.
Okay.
And in some cases, we still don't know how to manage these patients.
Okay. You've been both talking about plans. And there was a pandemic treaty between states. It was proposed by WHO in late 2020 and United Nations as well. But it was completely forgotten, and now we have a pandemic accord, milder, and not in, and it has been postponed to 2025. So, have we forgotten the pandemic too early? This is a question for all of you. Do we really risk not to be prepared to face another pandemic because we completely forgot what happened? It's a question for all of you.
I don't think that all the world has forgotten. Italy has forgotten to a large extent, because we should have statistics, not only statistics that monitor constantly what the population is doing, and we have a few like PASSI by Istat, but we should have samples of blood being tested constantly in sentinel patients, because that's the only way. And there are actually clear recommendations from WHO, as you said, and there are countries like the United Kingdom, the United States, Sweden, who systematically every year or every certain number of years take samples from the general population, every age group, every sexes, and look at what's new and what is changing, what is going down and what is going up. Problem is that our health system is so just able to do what is urgent, that that's why I was insisting that we need a vision. But the vision implies a good organization and somebody that do not want to do tit and tat all the time with every stupid issue that is raised by doesn't matter who.
Exactly. No, I agree. And I think there's one issue which we forget, and you're using Italy as an example, I can use Italy again as an example, that there is no centralized funding, because this is not something that you just do because you're looking for. It is indeed a vision, but it needs supranational funding, and it's a strategy that has to be managed beyond the boundaries of the country, because the virus will not see the borders. And I think that what we need is dedicated funding. Now we are investing in war, and we don't want to mix war with health, but the reality is funding is being invested in certain areas and not in others. There's a finite amount of money that we can dedicate to this type of issues. And unfortunately, I don't think that there is the same, let's say, willingness to bring together funds like they did to support weapons and whatever you want to call it. I'm not saying pro or against war, this is not the topic here, but I'm saying... Speak about the privacy. Yes, the privacy, not to talk about the privacy, exactly, yeah. So what I'm trying to say is that the same willingness to invest in a supranational activity that is needed, which I think we have the CDC in Europe, the European CDC, that does some of it, but it does with the basics, and it cannot interfere with the national level. And I think this is the real issue. Mark, I don't know if you share.
Plans and fundings.
Now, I mean, if I may add something about this treaty, I mean, the thing that's going on with this postponing is quite similar to the situation we got about the agreements about climate change, you know. It's the very same situation because politics is always in the way. So the main areas of disagreement in this case were linked to the fact that the WHO has been shown to be completely dependent on national governments in order to also issue warnings, you know. And we've seen that very well with what happened with China. And it's going to be a problem in the future as well, you know. Then individual, you know, governments were not really always that happy with the idea about, you know, public data sharing in advance, especially countries like China and Russia. Now, of course, we have other situations dealing with the war in Ukraine, the war in Israel. Of course, these things do not happen, you know, to keep the focus on this particular topic that was so important just a few years ago and now seems long forgotten, you know. Also, other issues that, you know, are kind of pressing concern the fact that many developing countries do not feel that they're going to be having equal access to the resources like vaccines and drugs that are going to be developed. So this is another area of disagreement. And obviously, politics doesn't really help to get, you know, straight to the point and to a finalized version of these treaty or agreement or whatever you're going to call it.
To speak about a treaty here in Italy, I don't know, Verena, if you want to add something, because we have 21 health systems.
Yes.
So maybe this is the problem. Here in Italy, we are really good in emergency, but we cannot see...
Yes, the problem
1 mile
is a really critical issue because in Italy, yes, we have 21 healthcare systems, and a patient from Rome.
How can we speak about a treaty?
Doesn't have the same rights of a patient in Trieste. We are lucky in Trieste and in this region, but not all regions had the same opportunities with COVID-19. I would like also to add another issue that I think that as doctors and clinicians, especially in the field of infectious diseases, we didn't collaborate as well as other colleagues did, especially in the UK and in other countries. And the result is that the main studies about COVID-19, about the drugs, and also the clinical features of the disease are not published by Italian scientists. So it is another issue. We have to improve a lot of things.
We have to. So now, if there are any questions, please raise your hands because we have 15 minutes for a discussion. While you are thinking about your question, I have another... Oh, do you? Oh, no. Okay. I have another question for all of you because you both, Marco and Oscar, have been talking about the media responsibility and the issue of information, which was really, really I mean, it was incredible. I was in there. And it was crazy, completely crazy, because everyone was speaking about things that they don't know. And so you have the need to be quick to give informations, because people wanted answers, but science doesn't always have such a quick answer. So the infodemic was a problem. So I want to just share your opinion about that. We are all in this together. Every one of us has a responsibility as a public, as a journalist, as a scientist. Everyone has to do something for this kind of mediatic environment. What do you think about it?
So I think the pandemic situation offers a great opportunity to the scientific community to improve, data sharing in a quick way and establish new collaboration networks. This is going to be a very good thing for the future. But at the same time, as you mentioned, we face this kind of infodemic. So everybody wanted to share everything as soon as possible, So even the usual quality standards that we use for, scientific publishing, meaning, peer review process, for example, were actually skipped. People used to simply, put online a preprint without any kind of evaluation by the scientific community. And I guess that the media, not being used to this kind of, explosion of information, actually didn't take into account the fact that a preprint is a preprint, is not a final study. And even the studies
they're
that
not
were
the same thing.
Many studies that have been published over the years in Insight were bad studies,
We
you
were
got hundreds.
We were submerged.
Yeah.
It was incredible.
Oscar mentioned
Every
before,
day,
several drugs like hydroxychloroquine, ivermectin, this kind of stuff. You can find hundreds and hundreds of studies that would theoretically support their use in clinical practice, but the point is that in the real life they do not work. They work in an in vitro system maybe, but you can kill a bacteria even with your kitchen salt. It doesn't mean that you can eat 10 kilograms of salt, You will kill yourself before killing the bacteria. So obviously, this kind of communication between scientists and the media has been difficult, because not all scientists, I would say that the overwhelming majority of scientists are not used to communicate directly with the media. So they're used to communicate with their own peers. And we have a way to actually understand what's good science,
what's bad science. We speak the same language, so you can understand each other.
Right.
Yeah.
So it's difficult.
But it's not the same.
And
with
on
the
the other hand,
public, it's not the same.
And I guess on the other hand, the media itself, some kind of media, I'm not saying that all journalists were the same. Luckily enough, there were plenty of them who were very competent, But many others just look for, the catchy title, And I've shown you very few examples about the many variants that didn't have any, biological meaning whatsoever.
We've made a lot of mistakes, Oscar. We were.
No, I think it takes two to dance. So the media definitely has a share on it, but I think there's something very bad about clinicians and researchers in general, protagonism. I think we had virologists on TV every day, people who actually spoke about, because it's nice to be on the spotlight. So I think there is protagonism. So protagonism with or without pandemics, I think that's a problem.
Yes, because it was not only the problem that scientists weren't used to speak with the media. They weren't used to speak at all, to speak to the lay public. Because,
but I think the issue here is we need to go in a stepwise. In a case of a pandemic, there's something uncertainty. It's like weather forecast. Let's think about weather forecast. They told me 2 days ago it was going to be raining today, and I didn't bring an umbrella, Now
she's saying in the afternoon.
So well, it might rain. No, there might be rain. So what I'm trying to say is that there is uncertainty. So in a weather forecast, if you go out and it says it's going to rain and you take an umbrella, you complain. If you don't take an umbrella, you complain because the forecast was wrong. So I think the issue here is, how do we manage uncertainty in communication? Now, science is not about...
We have to learn to
So science is not about the truth. It's about facts, and facts evolve as we collect them. Now, the media and the population is not used to deal with uncertainty. You don't like uncertainty. I want to know what I'm going to dress. They don't like probabilities. Exactly. Exactly. So I think for me is that the media has a role to make sure that everyone understands that uncertainty in new things is a fact of life. That we need to, so people would be preferring to, I don't know, when we say, oh, there might be a risk of an accident when you when you take an airplane. There's also a risk when you take a car. But of course, when a car hits another, perhaps you may be alive. When a flight falls off the sky, perhaps it's more unlikely that you have survivors. So I think, but dealing with that type of uncertainty and quantifying that in a discussion is always challenging. Now, specifically the issue we had, and Marco already alluded, is translating efficacy and not talking about safety. So it's always benefit and risk. That benefit and risk discussion never occurred. Oh, it's working, let's try. And this is, I think, was the worst part in it, that people tried based on poor communication. The other thing is politicians meddling with science. Yeah? This is something that is also a problem. I mean, politicians are not scientists, and scientists are not politicians who should define policies. Yeah? I guess there was no clarity about roles and duties, and this is an issue that the media didn't help with.
The journal Science has endorsed the Democratic Party in the US. It's not a good thing, I think. Verena, do you want to say something?
Yes. In a emergency period, it's important also that the media let speak maybe not only scientists, but at least not everybody, because in Trieste, I don't know if you remember, but we experienced a really bad moment at the end of the 2021, because we had a really great anti-vax movement, and the media didn't help so much. Also politicians, but also the media.
Yes, because they are not so many, the anti-vaccine, but they and the media didn't help. That's true. Yeah.
However, let's not forget that we have had the guarantee of the privacy in Italy for many years by now, that basically made impossible to really access and analyze properly health data at the top of everything. And the Garante is pretty independent also from political power. It's a sort of autocratic, obsessed role that basically made doctors unable to read even their own data. And when ignorance is there, everything becomes more dangerous.
That's true. Does anybody have questions? Yes, over there. Thank you.
Hi. Oh, okay. Hi, Kajetan Paszek, University of Wrocław, Poland. Thank you so much for this interesting lecture. I have two questions to Marco. The first one would be, we all learned the mRNA and DNA vaccines due to COVID-19 because the vaccine was mRNA. It was coding the spike S protein. So do you think that this invention can possibly bring new solutions to the problems with viruses that do not have their vaccines yet? And the second question is maybe more to Silvia, but also to Marco. What do you think about the possibility of a pandemic caused by a virus that has a bigger deadliness than the contagiousness? For example, Ebola viruses, Marburg viruses, cholera viruses. Do you think that they pose a threat, or do you think that as long as they are contained in like one place, such as Ebola virus actually didn't leave the western coast of Africa, do you think that they pose a threat, or do you think that they are, as long as they are like contained in this one place, it's not a pandemic rather than like an epidemic? Thank you.
So thank you very much for the question. I'm going to try to answer to the first part. Maybe I'm leaving the second one for somebody else. So mRNA vaccines are great technology. So the pandemics really gave us the opportunity to really taste this on the large scale. So the idea is that you can deliver, and make deliver a product that would enable the direct production of a target protein by the cells of the host themselves. So it has great, potential not just for the development of vaccines, but also for other kind of applications. So you probably heard about things that are called vaccines, but are not really vaccines in the way we actually traditionally think about them. That could be used also for, in the field of oncology, for example. So this is something that holds a lot of...
We have RNA drugs.
Yeah,
now.
exactly. So
it's
these
a
things
revolution.
also a lot of premises. So as any new things, of course, there are concerns about the safety, the opportunity to use it in different contexts. But of course, it is a great platform that offers many improvements compared to traditional kind of vaccines. And we're also seeing it in terms of efficacy for SARS-CoV-2 vaccines. As you know, there have been other type of vaccines developed, so we didn't have them that much in Europe, but traditional vaccines like the Sinovac and stuff like that have been widely used both in China and in South America, and in insight, their efficiency has been much lower compared to mRNA ones. So obviously, these are probably the kind of vaccines that we're going to see more and more in the future.
We only have time for the answer to the second question. Do you want to? Oh.
The epidemiology of infection teaches us that paradoxically, the more lethal an infection is, the less there is scope for an epidemic. This, of course, is not to wish us a very, very deadly virus, but it's true that it's true that the smart viruses generally become smarter and smarter, but I think that's not the real the danger, the real threat. And thank you.
Yeah, so just I think about the Ebola case in Africa. So you have to be careful because you have dengue now in Italy.
Yeah.
We have dengue in Europe, yeah? So
Yeah.
climate change, Mark already said, so we cannot say that because it's there today, it's not going anywhere else, yeah? So the climate change is affecting. And the other issue is that once you get the infection, and you're not prepared, coming back to preparedness, you spread it, and even though it's not a pandemic, it may lead to further mutations that also make it adapt to the new environment.
So with this not so good news, okay, thank you everybody for coming. Thank you for coming and to be here with us, and have a good day. Bye.
Thank you.